Thank you for joining the JICA COVID-19 webinar on Japan's public health approach for COVID-19, past, present, and future today. Audience from all over the world, you are very welcome to hear me here. Good morning, good afternoon, and good evening. I'd like to give you some housekeeping information about interpretation function. There are simultaneous interpretation service provided in English and in French. So please select your preferred language to enjoy the presentation and discussion using the interpretation button. Please do not hesitate to ask questions to the speaker through the Q&A function. We'd like to have discussion time as much as possible. So we will be delighted to have your comments and questions during and after speaker's presentation. You can write questions in English or French. Please remember using Q&A function for questions, not chat box. We are going to record today's webinar and upload the video on the YouTube channel of JICA Ogata Research Institute later. For your reference, we have uploaded today's presentation material already in the cloud. Access information is the reminder email we sent 1 hour ago and in the chat message. Once again, good evening, everyone. Let's begin the webinar. I'm Saida Makimoto from JICA Ogata Sadako Research Institute for Peace and Development, serving as MC today. Very nice to meet you all. JICA, Japan International Cooperation Agency, engages in development cooperation across the world as a bilateral ODA cooperation agency of Japan. In COVID-19 pandemic, JICA is maximizing its cooperation to protect people's lives and build more resilient societies based on the strong partnership and trust we have built with the partners around the world. We are taking a holistic approach focusing on prevention, precaution, and treatment. As one of its activities, JICA has launched this webinar series to share the latest and practical knowledge, as well as research findings from Japan with other countries, especially low and middle income countries. In this webinar series, we are going to invite various leading professionals and researchers in Japan as speakers each time. Today's topic is public health approach in Japan. As you may know, Japan is known with a low number of deaths despite having one of the world's oldest population and densely populated cities, and while not locking down strictly and taking a unique approach. Although a low number of deaths is much less than, also the number of deaths is much less than Europe or United States, it has increased rapidly since the end of last year, and a state of emergency has been declared for this third wave. At this moment, various discussions are actively taking place on the review of countermeasures. Today, we'd like to invite Professor Hitoshi Oshitani as a notable speaker to talk about the past, present, and future of Japan's public health approach for COVID-19. Professor Oshitani is a professor of virology at Tohoku University Graduate School of Medicine in Japan, and he sits on several expert advisory groups to guide Japanese response. Professor Oshitani is known internationally for coordinating the response to SARS during his work at WHO Western Pacific Regional Office. It's very exciting to have him with us here today. Professor Oshitani, thank you for joining today. The floor is yours.
Thank you, Makimoto-san, for introduction. It's my great pleasure at this the JICA webinar series to share our experience in Japan. And good morning, good afternoon, and good evening, everyone. And I'm sure you have many questions. So I will start my presentation. I hope you can see the screen. And the title is Japan's Public Health Approach for COVID-19, the Past, Present, and the Future. So I will briefly explain what we have been doing to respond to this COVID-19 pandemic in Japan. And as you all know, the COVID-19 is caused by the SARS-CoV-2, SARS coronavirus 2, which is virologically similar to the SARS coronavirus, which is the causative agent for SARS in 2002 and 3. But we are still not sure how this virus emerged in the human population. The natural reservoir is the most likely to be the bat, but we are not sure how the virus transmits from the bat to the human. And it's probably some intermediate host that were involved between bat and human, but we are not sure what the animals that were involved between the bat and human. And although the virologically, the SARS-CoV, the SARS coronavirus and the SARS-CoV-2 are similar, the consequences of SARS and the COVID-19 are quite different. For SARS, the total number of reported cases to WHO, there was the 8,096 with 774 deaths. And the SARS was successfully contained by the July 5th of 2003. But on the other hand, for COVID-19, since the first report of COVID-19, the more than a year has been passed, but still number of cases is the rapidly increasing. And the last night, the Johns Hopkins University website, they posted the updated figure, which indicated that over 100 million cases have been identified worldwide, with more than 2 million deaths. And since the beginning of the COVID-19 outbreak, I've been thinking what made the SARS and COVID-19 so different. As Makimoto-san mentioned, I was working in the WHO Western Pacific Regional Office during SARS in 2002 and 3. And so there are some significant differences between SARS and COVID-19. For SARS, the majority of infected individuals develop very severe illness. And that's why the case fatality ratio was quite high. But due to this characteristic of SARS, that we managed to identify most of infected individuals. And we managed to identify most of transmission chains, starting from Guangdong province of China, and the virus spread to different countries through Hong Kong. And we managed to trace the pathways. But for the COVID-19, it's quite different. As you probably know, for COVID-19, many infected individuals develop very mild illness or even asymptomatic infection. So asymptomatic infection is quite common, and which makes this virus invisible. So the usual surveillance system cannot detect all cases, and many cases are being missed in different countries, most of countries. And then suddenly the large number of cases appeared in one community. In most of cases as a cluster. The cluster means the the cluster of the cases in one setting. And the significant difference between SARS and COVID-19 is the timing of infectivity. For SARS, most of infected individuals did not have any infectivity at the onset of illness. And they became only infectious when they developed the very severe symptoms, usually the severe pneumonia or severe diarrhea. So that's why we managed to contain SARS by isolating most of the possible cases when they developed symptom at the onset of symptom. But for COVID-19, it's totally different. The infectivity, the peak of infectivity, they occur even before the onset of illness. So for this kind of infectious disease, containment is extremely difficult because even if you isolate all cases after the onset of illness, it's too late. That they may have already passed the virus to others during incubation period. So for this kind of virus disease, infectious disease is much more difficult to contain. And also the pathogenesis is different. And so this is the main reason why the SARS and the COVID-19 have different clinical and epidemiological characteristics. For SARS, the majority of infected individuals had very high virus load deep in lung, in lower respiratory tract, and not much in upper respiratory tract. That's why for SARS, they were not so infectious. But for COVID-19, some patient is exactly same as a SARS. And the virus replication mainly occur in lower respiratory tract, deep in lung. But for some patient, the virus replicate both in upper respiratory tract and the lower respiratory tract. And they may be quite infectious. They have a more ability to infect others. And also there are some individuals who do not have a much virus in the lung, in the lower respiratory tract, but high virus load in upper respiratory tract. So the infected individuals do not develop severe symptom, but they may be quite infectious and they have ability to infect many others. So that's for the two categories, that make the COVID-19 more difficult to control. And so from the beginning, we knew that containment is quite difficult or almost not feasible for COVID-19. So from the beginning, this is our objective of the COVID-19 response in Japan, so which is to maintain the social and economic activity as much as possible while suppressing COVID-19 transmission as much as possible. So we did not aim at the containment from the beginning. And so these are the early cases in Japan. We had some imported cases from China, and also some cases who had the contact with the travelers from China. So the very first case, it was identified on the January 15th, and the onset of this case was January 5th. And then since February 17, we saw the sudden increase in the locally acquired cases. These cases were unlinked with the travelers from China. And then suddenly our number increased since the mid-March. And this was triggered by the imported cases from different countries, including Europe, North America, Southeast Asia, and so on. And then state of emergency was declared on 4th 7th of April, and but then number of cases decreased, and on 25th of May, the state of emergency was lifted from all areas. And so in this early stage of outbreak of COVID-19, we found several important epidemiological findings. The first one is that there was very low positive rate. We observed a very low positive rate among close contact of confirmed cases. And a similar finding were obtained in different countries, including China, Europe, and some other countries. So the positive rate among close contact were quite low in different countries. But as you know, by that time, the SARS-CoV-2 has spread to many countries, including not only in China, but also in Europe, Middle East, and some other regions. So although the positive rate among close contact was quite low, we observed the rapidly increasing number of cases in many different countries. And we were wondering why such thing happened. And you probably know that the basic reproduction number, R0. And the R0 is, the definition of R0 is on average how many people are infected from one infected person. If R0 is just 1, there is no outbreak. It's stable. One person can infect just another person, and there is no outbreak. The R0 is less than 1. There is no outbreak, and outbreak will be subsided. And if the R0 is the more than 1, the exponential, the growth, they can occur. And so the only possible explanation why the COVID-19 transmission was sustained, even though the majority of infected individuals did not pass the virus to anybody else, is like this. So if the majority of people do not infect others, and the only some people infect 1 or 2 the others, the outbreak cannot be sustained. But if some individual infect many others, by creating the cluster or the super spreading event, the sustained transmission is possible. So we believed that this is how the COVID-19 transmission was occurring. And the Professor Nishiura's group, he's now the professor at the Kyoto University. His group had the preliminary data which indicated that actually the majority of infected individuals did not pass the virus to anybody else. Close to 80% of them did not pass the virus to anybody else. But the small proportion of infected individuals infected many others. And also the analysis of the early cases in Japan show that actually the majority of the people do not pass the virus to anybody else, but the small number of people like this one, this person infect many others in different occasions. So this kind of the cluster or super spreading event, we believe that this kind of super spreading event is a key for COVID-19 transmission. So this is the diagram showing the basic principle of epidemiology of the COVID-19. So the cluster or the super spreading event is probably the necessary condition for sustained transmission. And so this kind of the infection transmission to the one or two people, they may occur especially in household, but these transmission is actually these transmission chains are actually dying off, disappearing, and only the transmission can be sustained when the clusters occur in the community. And so these are the two possible mechanisms for large outbreak of COVID-19 to occur. The one is a chain of clusters. So the cluster-to-cluster transmission occur. You may see the outbreak in the community. Or if there is a big cluster, we call it a mega cluster, then you may see the large outbreak in the community. And in the world, there are many report regarding the mega cluster in the religious gathering and some the event. And so this is another possible mechanism for the large outbreak of COVID-19. So based on these early findings, the Ministry of Health, Labor and Welfare, they established the cluster task force within the Ministry of the Health, Labor and Welfare, and we established the basic principle of our cluster-based approach. And so another unique thing in Japan is that we've been conducting the different type of the contact tracing. So this is a usual contact tracing, called prospective contact tracing. In many countries, when you identify the confirmed cases, you also try to identify the close contact of confirmed cases, and then they follow up the close contact. And if there is any symptomatic cases, or you are testing these cases to identify the infected individuals. So we are also doing this the prospective contact tracing. But in addition to the prospective contact tracing, we are also doing retrospective contact tracing, because the prospective contact tracing is not that effective in identifying the cases. That since, as I mentioned, the positive rate among close contact is quite low for the COVID-19. So you may have some cluster in the community like this, but the problem is, as I mentioned, the COVID-19 is quite invisible. Meaning that the usual surveillance system, they cannot detect all cases. In most of the cases, some cases are missed by the surveillance system. So if we cannot detect these cases, especially those who create the cluster that are missed, and we may have a large outbreak undetected in the community. So, and another problem with the COVID-19 is the pre-symptomatic transmission. And as I mentioned, the peak of infectivity is during the incubation period. And this analysis in the Lancet show that about 45% of infection may occur during the pre-symptomatic phase. So this is another reason why this kind of the prospective contact tracing is not that effective in interrupting the transmission, because this case, when you find this kind of case, it may be too late to interrupt the transmission. So we are also, that's the reason why we are also doing the different type of contact tracing, which is called as a retrospective contact tracing. When you find some cases in the community, we try to identify the source of infection. So this is called as a retrospective or the backward contact tracing. And so as I mentioned, the SARS, this COVID-19, there cannot be transmission of COVID-19 cannot be sustained without forming the clusters. So when you find the source of infection, so this source of infection might be a cluster like this. So then you can find many cases around this cluster. So, and there might be some additional cases. And you may be able to interrupt this kind of the transmission by identifying the cluster early enough. The cluster itself cannot be prevented, but the further cluster, from one cluster, that can be prevented. So this is the diagram showing the concept of the contact tracing in Japan. We are also doing the prospective contact tracing, but in addition to prospective contact tracing, we are doing a retrospective contact tracing to identify the common source of infection. And so the public health nurses in Japan are using these forms, the different forms, including the case reporting form, the source investigation. This is a retrospective contact tracing, and the usual prospective contact tracing. So for retrospective contact tracing, they ask the infected individual for their activity in past 14 days from the onset, to identify the common source of infection for them. So this is what we've been doing in Japan. And as a result, we identified the clusters. This is one of the example, which was the clusters in the live music clubs in Osaka in March. And so by conducting the retrospective contact tracing, we identified the cluster in the live music club. Then we did both the retrospective and the prospective contact tracing. And the contact tracing identifies the link between the different clubs, and also the link between the people who were at these clubs, the infected, some family members or the occasions. So this is how we've been conducting our contact tracing. So the contact tracing in Japan is being done by public health centers. We have quite a good network of public health centers. A total of 469 public health centers exist in the different prefectures and the major cities. And there are more than 28,000 officers stationed in these public health centers, including more than 8,000 public health nurses. So these public health nurses are the ones who are mainly doing the contact tracing. So they are trained as a public health nurses. And they have also received on-the-job training for the contact tracing. And also the retrospective contact tracing is one of their routine work, they are doing this type of contact tracing routinely for the infectious disease investigation, particularly for the TB cases, tuberculosis cases. So that's why before we established the cluster-based approach in Japan, the public health nurses, they were already doing the retrospective contact tracing to identify the common source. And by implementing the cluster-based approach, we may be able to interrupt the chain of clusters, as I mentioned. And also, another advantage of the cluster approach is that we manage to identify the common characteristics of clusters. And so based on the analysis of the many clusters, that we identified common environmental factors in which the most of cluster were occurring. So these common characteristics included the closed space, the crowded places, and the close contact setting, such as a close range conversation. So this is quite the popular notion in Japan. Even the primary school kids, they know this the concept, and that we managed to send the more effective public health messages to general public by identifying these common characteristics for clusters. And the further analysis of the cluster identified additional risk factors such as exercise, the talking in loud voice, singing in karaoke and other occasions, and also the nightlife settings. So these are the main risk factor for cluster to occur. So, and also a large cluster can occur in healthcare facility and the nursing home, and which result in many severe cases and deaths. And so these are the finding of the analysis of a cluster. And then we also analyze who transmit the virus in the cluster. So actually, half of cluster were caused by those aged 20 to 39 years, the relatively young people. And so the bar indicated the age distribution of total cases. So this is an analysis by the early April, but those who they infected many others are relatively young, and they are quite active, and they are less likely to develop severe symptoms. That's probably why they are likely to be the primary cases for the clusters. And also, we identified that the more than 40% of clusters were caused by those in asymptomatic period. And also, by analyzing the many clusters, as I mentioned, we identified the talking, especially the talking in loud voice or singing, is a major risk factor. And also the pre-symptomatic transmission, the commonly occurred in cluster, which indicated that there's some unusual mode of transmission that should take place for COVID-19 if the only droplet and contact transmission that occur for COVID-19, this kind of thing cannot happen because the pre-symptomatic people do not cough or sneeze. But even if they do not cough or sneeze, they transmit the virus to many others. And we believe that there must be additional route of transmission, which is likely to be the short-range airborne, the aerosol transmission. And at least the short-range aerosol transmission can occur for COVID-19. That's what we consider from the beginning. And this is the epidemic curve of Japan, in Japan, from June to September. And after the state of emergency, as I mentioned, our number decreased, but again, the number of cases increased from the end of June. And this was mainly because of clusters in the large nightlife entertainment areas, especially the nightlife entertainment area in Shinjuku in Japan, in Tokyo. And so most of the cases in the June, July were associated with the nightlife entertainment settings. And it took some time to control the outbreaks in these settings. That's why we had quite a large number of cases in the July and August. But after implemented some control measures in these nightlife entertainment areas, number of cases decreased again. And so this is the diagram showing what happened in May to July. And as I mentioned, probably the cluster-to-cluster transmission that occurred in the large nightlife entertainment areas, particularly in host and hostess clubs. And then the virus spread into the community, into the household, schools, the other restaurants and the bars, the workplace, and so on. Then eventually the virus reached to the hospital and the long-term care facilities, such as the nursing homes. And the most of the severe cases, they occurred in these settings. And so this graph shows that the bar chart indicated the cases in hospital and social welfare facilities, such as the nursing homes. And this line shows the total number of cases. Actually, the outbreaks in hospital and the long-term care facilities occur at the end of the outbreak, mainly occurring at the second half of outbreak. And this is probably because these settings, hospital and nursing homes, the dead end of the transmission. So after the virus spread in the community, then leads to these settings, and then there is no more the transmission. But in these settings, we saw many severe cases and the deaths. And so this is our more updated analysis. We have identified nearly the 15,000 cases. We have analyzed nearly the 15,000 cases. The pattern is still the same. The majority of the infected individual that did not pass the virus to anybody else. But a small proportion of infected individuals infect many others. So this characteristic is called as the over-dispersion characteristics. And the over-dispersion characteristics is still seen in Japan. And also the most of clusters that are caused by the relatively young people. And so the pattern is also still the same in Japan. And the similar findings are found in the other countries. So the data is from Hong Kong and from Ben Collins group, and they also found exactly the same pattern. And also this study is from India, and they show that about 5% of infected individuals infect the rest of the cases. So and the majority of infected individuals did not pass the virus to anybody else. And also the illustration is in the Science magazine, and they summarized what we've been doing in Japan. And they showed the super spreading event is quite important, and the super spreading event is occurring in different places like bars, the sport gym, and so on. And the retrospective contact tracing is important, and also the 3 Cs concept is also shown in the diagram. And also the WHO Western Pacific Regional Office, they posted several materials indicating the importance of 3 Cs. And this is our current situation. As of now, we also had the increasing number of cases in December due to the several different reasons. One is it is summer, it is winter in Japan. The cold weather, we are not sure how the cold weather affect the transmission pattern of the SARS-CoV-2, but also in many other countries, the number of cases increase in winter, and also we have many occasion for the parties that may facilitate the transmission of the COVID-19. And then we declared the state of emergency on the January 7th, and the now number of cases is decreasing. But it's still too early to know what is going to happen in the next few weeks. And we are closely monitoring the situation in Japan. And also, this is the age distribution of fatal cases, and most of deaths occur in the elderly people. As Makimoto-san mentioned at the beginning, we are living in a highly aging society, and most of these deaths occurred. Probably more than half of these deaths occurred in the long-term care facilities and hospitals. And it's a big challenge for us to prevent transmission to these settings. And also, the most of cases have been occurring in the large cities, in the metropolitan areas, especially in Tokyo and Osaka, and some other places. So Tokyo has highest cumulative number of cases per the 100,000 population. So the COVID-19, the control is much more difficult in the high density population, like in metropolitan area of Tokyo. And so this is also the big challenge for us to establish the more effective control measure in these the metropolitan areas. So we are not just rely on cluster-based approach. We are implementing the different measures, including general precaution measures, the basic the measures, and also when we observe the increasing trend of cases, they implemented some enhanced measures, such as limiting the business hours for bars and restaurants. And now the government declared the state of emergency for the 11 prefectures, including Tokyo and Osaka. And the further enhanced measures are being implemented in these areas. And we have not implemented the lockdown measures in Japan. And we hope that we can manage the current outbreak. So these are the further the information. Thank you very much for your attention. I'm happy to answer any questions. Thank you.
Thank you very much, Professor Oshitani, for your comprehensive introduction on Japan's approach for COVID-19 and sharing your insight. From now, we'd like to have a Q&A session. I'd like to invite two colleagues from JICA, Dr. Mitsuo Isono, Senior Advisor of Human Development Department, and Dr. Go Tanaka, Executive Technical Advisor of Human Development Department. Dr. Isono, over to you.
Professor Oshitani, thank you very much for your very excellent presentation. I'm Dr. Isono, working as a senior advisor at JICA headquarters. So from now, we'd like to have the Q&A session, and we already received so many questions even before this webinar. So I'm afraid that we cannot answer all of the questions. So today we'd like to focus on the questions regarding the epidemiology and public health measures for the COVID-19 based on the Professor Oshitani's lecture. So at first, there is a general question. So in African countries, or maybe low middle income countries, there are some countries where the incidence of COVID-19 is low. So what is your opinion of this phenomenon? What is the reason of the low incidence in some African countries?
Oh, it is the good question, but it's difficult to answer. There might be several factors involved in the low incidence in some the African countries. One is the connection between countries, and the volume of travelers is quite different. But still, there are a lot of the travelers from between Africa and the Europe. But the African countries had some time to implement the measures in early stage of the infections to prevent the importation of the many cases. And like in Japan, by end of April, we have identified over 300 imported cases from different countries, and not only from China, but also from many other countries. And that the volume was too high to control the outbreak. As I mentioned, the majority of infected individuals do not pass the virus to anybody else. So if that volume is small, you can manage to control. But if the volume is too high, then it's become very difficult to control. In Europe, probably virus has already arrived in Europe by December 2019. Then the virus has already spread to many countries when they identified the first cases. And it was very difficult for Europe and the North American countries to control the COVID-19. And then without any identification, the virus has already spread to the South American countries. And so there are also the many other possible reasons, but we need to analyze more data to answer this question.
Thank you very much. Another general question is regarding the herd immunity. So, current condition of the spreading of this infection will evoke the herd immunity, or how can vaccination will accelerate this process?
It's probably very difficult to achieve herd immunity by natural infection. Even in the US, the seroprevalence is not that high to achieve the herd immunity. As you know, there are a huge number of cases in the US. And so we need a vaccine to achieve herd immunity. And vaccine are already available in some countries. And in Japan, we are hoping that we can start the vaccinating some people in February. We are not sure that when the vaccine will arrive, but the only vaccine can achieve the herd immunity. But there are still many uncertainties regarding the vaccines, including the safety and the effectiveness. And some preliminary data show that these vaccines are quite effective, but we are not sure if these vaccines can achieve long-term immunity. So there are many uncertainties, but without vaccine, I think it's very, very difficult to achieve herd immunity.
Thank you very much. So next question is regarding the contact tracing. There are so many questions regarding the contact tracing. So at first, what is the criteria among the contacts to conduct the PCR testing? Or what is the criteria to isolate the contacts? What is the Japanese criteria?
It's changing, and it also depends on the situation. And now, as I mentioned, the number of cases is has rapidly increased, especially in large cities. In these places, it's difficult to follow the original rules, and so they're using the different approaches, the modified approaches. But in general, we are initially testing those who the physician think that the testing is necessary. When the physician think that the testing is necessary, and then the public health nurses do the contact tracing, and then the close contact, especially in those in the possible clusters, all of them were tested initially, but including asymptomatic cases. But it is getting very difficult to test all cases. So now, in most of cases, the symptomatic individuals are being tested, and also in some situation, like the nursing home or hospitals, the more proactive testings are being done. Even the asymptomatic individuals are being tested. If you identify some cases in the nursing homes or the hospital, so it depends on the local situation and also the setting where the cases occur.
Okay, thank you very much. So next question regarding the contact tracing is the retrospective tracing. So what is the significance of the retrospective tracing? And also there is some question for the methodology. So actually, how many cases could you find by this retrospective contact tracing? And also among the retrospective contact, there are so many unknown people. So how can you make this retrospective tracing effectively?
So thank you for question. For the retrospective contact tracing, we don't have exact number how many the clusters were found by retrospective contact tracing, but we have already found many clusters. I can't remember exactly, but over 2,000 the clusters have been found in Japan, and without the retrospective contact tracing, I'm sure that we could not identify such many clusters. And we analyzed some data in the small areas, and actually the many clusters are found as the result of the retrospective contact tracing. And but it's quite difficult to distinguish which one is found by the retrospective one and which one is found by the prospective ones. And we need to analyze the more data. And also for some clusters, the retrospective contact tracing is quite challenging. For example, in nightlife entertainment settings, some people do not tell the truth. Even if they visited certain the bars, they do not tell the truth. So it's quite challenging for the public health nurses to get the real information from these individuals. But still the retrospective contact tracing is done for these settings by public health nurses. Public health nurses they spend so much time to interview each infected individual. So another challenge for the retrospective contact tracing is it's quite time consuming and labor intensive the method. So when you have the large number of cases in the community, the retrospective contact tracing is not feasible. In such case, you have to reduce the number of cases by implementing the more aggressive physical distancing measures. And that's why the government declared the state of emergency right now, and to reduce the level of transmission. And now the number of cases is significantly decreasing in Tokyo and some other areas. But we need to see when we can restart the retrospective, and also even the prospective contact tracing is getting more difficult in some areas. So we need to see when we can restart the contact tracing in such settings.
Thank you very much. And some cases infect others during pre-symptomatic period or maybe asymptomatic period. So it seems that this phenomenon makes contact tracing a little bit difficult. So what is your suggestion on this point?
So the pre-symptomatic transmission is quite challenging. The first when you identify the cases, the person may have already spread the virus to many others. And also if the pre-symptomatic transmission occur, then this person is quite fit when they are infectious. So they are quite active in the social activities. They're going to gym, going to bars, and so on. And then such person may infect the many others in the different occasions. So which makes the contact tracing more difficult. And also especially in the restaurants and the bars, the customers, they may come from different places. So the contact tracing, especially retrospective ones, are more challenging in these settings. The workplaces or the family are much easier to implement the contact tracing, but the certain settings are more difficult, especially when they infect others, they in pre-symptomatic phase. And this is one of the reasons why the containment of COVID-19 is quite difficult.
Thank you very much. Next question is regarding the infectivity. So some people, only some people infect others, while most of the people, I think you mentioned nearly 80% do not infect others. What's the cause of differences? So the person who can infect others has some characteristics.
So we are analyzing some data, but we still don't know why the certain infected individuals are more infectious, much more infectious than others. The one possible explanation is the difference in the virus load in upper respiratory tract. Actually, the virus load is quite different between infected people. So some infected individuals shed the large amount of virus, even without having severe symptoms. So these people are probably more the infectious, and but from our analysis, many of the infected person who infected many others are relatively young, and this is probably due to the social reason, not biological reason. And the young people have a more chance to be in the large social gathering, and they are more active in doing the different things, going to gym, the bars, and so on. And that's both the biological and the social factors are probably involved in as the important factor for some individual to be the more infectious and transmit the virus to many others. Thank you.
Thank you very much. So this explanation is same to the super spreader. Is there any characteristics for super spreader?
The WHO does not use the term of super spreader because it's not just the host factor. It's the combination of host, environmental, and maybe some other factors, social factors. So, but those who create the clusters are exactly the same as a super spreader, so-called super spreader.
Thank you very much. So the next questions are related to the public health measure to avoid 3C. You summarize several recommendations to avoid 3C. So what is your recommendation regarding the best way and simple way to avoid 3C? For example, there is one question from the Indonesia that the public transportation is very crowded, like a bus or is very crowded. So how can avoid infection in those conditions?
So the public transportation is possibly the risky environment, but we have not seen many cases associated with public transportation. And the one possible reason is it's quite difficult to identify the clusters in the public transport. But also now we are trying to reduce the number of people in the public transport, and by staggered the commuter, and we recommend to go to the office or the schools at the different the time, and so now actually the subway in Tokyo are world famous with the heavy the crowds, but now the station is much better, and that's one possible solution. And also we recommend to have the good ventilation. Even in a subway in Japan, they are opening the windows, and which is quite effective to have a good ventilation. The 3 C's, the first C is the closed environment with poor ventilation. So if we have a good ventilation, you can reduce the chance of transmission. And also we recommend to wear the masks. And the majority, probably 99% of the people are wearing a mask in public transport in Japan. And also we recommend not to talk in the public transport. And so these are the keys to reduce the chance of transmission in the public transport.
You clearly mentioned that not only 1C is not so dangerous, so to avoid 3C is very important. And so and you recommend several recommendations to avoid 3C. So what is other big measures like a lockdown or state of emergency to avoid 3C? What is your opinion?
So to avoid the 3 C's, there are different approaches. But during state of emergency, we recommend the people to stay at home as much as possible, especially during night. And at the same, but in certain settings are more dangerous, more risky, especially the restaurants and the bars, when they drink too much and they talk a lot, and in many cases they do not wear the masks, and so these the highly risky situation should be avoided. And so by avoiding these the risky situation, you can reduce the number of transmission significantly. And but we are still struggling to send the public health messages to the hard reach people, especially the young ones. We have to use the different channels to send our public health messages to the young people, and they usually do not read the newspapers, and some of them even do not watch TV. And so we have to use social media and some YouTubes and other medias. And we are still struggling to send the effective public health message to the young people. And this is I believe that it's quite important in all countries, because the young people are the main source of clusters.
Thank you very much. So just you address to this communication, and also you are working as a government advisor for the government, and what is the important point for this communication? For example, within the governments or within the stakeholders, and also this communication to general population. What is your recommendation?
So this communication is quite challenging, and in most of countries, including in Japan. And as I mentioned, we are having a hard time to reach to the young people. And this is one of the biggest challenge for us. And also this communication to the certain the business entities, like the bars and the restaurants. We've been seeing many clusters in bars and restaurants, and also karaoke and so on. And they have to modify their business, but it is not easy to change the pattern of business suddenly. But we have to communicate with them. I don't think the COVID-19, the pandemic, will be over in several months. So it will last for some time. So they have to have a more long-term vision to change their business. And this kind of this communication is also quite challenging, but we have to communicate with the many different the people, and also now the elderly people are very, very cautious, but because it's easy to access to them. They are reading newspapers and they are watching the TV most of the time, so now they are following the proper precautionary measures. But there are some the people who are difficult to access and who are difficult to change the behaviors, and so we still have many challenges in terms of risk communications.
Thank you very much. I think this is a very, very difficult problem. So another question, there is some question regarding the reinfected cases. So what is the incidence of reinfected case in Japan, or what is how do we consider these cases?
We have to distinguish between reinfection and the reactivation. And we've been seeing many cases with reactivation. That means that the infected people could not clear the virus completely, and the same virus in the body replicate again after some time. That's reactivation. And the reinfection is the infection with the virus again. But the incidence is not that high in Japan. That we have some report of the possible reinfections, but we have to confirm that the second infection is caused by the different virus by analyzing the sequence of the virus. And I don't think we have the confirmed reinfection in Japan. But in other countries with a high incidence, there are several reports of the reinfections infected by the different virus in the second time. And we don't know the significance of the reinfection, and the cases that developed more severe infection in the second time. So we have to know if the reinfection is common, and also reinfection could be less severe or more severe. And there are a number of the important research questions regarding the reinfections, but we have to wait for more data to come to answer these questions.
Thank you very much. And still we have a lot of questions unanswered, but we are very sorry we don't have enough time. So before handing to Dr. Tanaka, this is last question. So Professor Oshitani, you kindly presented measures, the recommendation for the public health measures. So once again, I'd like to ask you, what is a recommended measure or essential measure in resource-limited country, like low-income income countries? What is your essential recommendation for the public health measures?
So the most important thing is early detection and early response. If there is no widespread transmission, you can manage to control this virus. And especially in the rural areas, it's not that difficult to control. In Japan, the majority of infections have been occurring in the metropolitan areas. And in most of the smaller prefectures, they managed to control the COVID-19 in the very early stage. And even if you have the cases from the metropolitan areas, they managed to control. So it's the control of the COVID-19 is quite difficult, but if you can detect the cases early enough, it's not that difficult to control. So the early detection and early response is a key to control the COVID-19. So every suspected cases that should be tested earlier, and you have to establish the system to detect these cases. And once they're detected, you have to do the proper contact tracing. And in early stage, especially in early stage, retrospective contact tracing to identify the source of infection is quite important to interrupt the chain of transmission.
Thank you very much. So now I'd like to hand over to Dr. Tanaka for the additional special discussions.
Okay, you must be tired, but let me ask a few questions. So as you mentioned that we understand the early detection and early intervention is very important from your lecture. But another people say that, as you said, there's 100,000 positive cases. So what do you think that there's from the another way of the public health point of view? We always follow the positive cases, but some people say that we should only care for the death cases or severe symptomatic cases. What do you think that especially for the mass media point of view, they only allow following up the number of positive cases? What do you think?
The number of severe cases, the volume of severe cases depends on the volume of total cases. So to reduce the number of severe cases, we have to reduce the total number of cases. And as I mentioned, usually the virus that transmit from the young ones to their family members, then to their workplaces, then they reach to the grandparents' generation in the nursing homes and hospitals. So to prevent the transmission to the elderly, the best way is to prevent the transmission in the young ones. And so the young ones usually do not develop any the severe symptoms, but it's still very important to reduce the number of cases in young people, even if they do not develop the severe symptoms. Otherwise, we cannot reduce the number of severe cases and the deaths. And that's what I believe.
Oh, and the other way of saying, we for the you put the importance to the starting point is getting from like restaurant and the eating places. There's a cluster gonna happen from those areas, but seeing that for the this third wave, there are so many cases, and we see the the cluster happened in the more in the home setting or nursing home setting, but still it seems like we still put too much importance on the the restaurant, the eating situation. What do you think we should because it takes a lot of resources, and the situation is the public health nurses, number of public health nurses, so there's limited situations. And some people say that we should put more importance to protect the aged people. So, what do you think your strategy? Let me know.
So the protecting elderly is quite important. I agree that the protecting the elderly is probably the most important in the COVID-19 the control strategy, and we do recommend that the more proactive the measures to be implemented in hospitals and nursing homes and other long-term care facilities. At the same time, as I mentioned, we've been monitoring many clusters, and before reaching these settings, hospitals and the nursing homes, and in most of cases, the outbreak started. Actually, outbreak initially amplified in the setting like bars and restaurants. Then the virus spread into the community and then reached to the nursing homes and hospitals. So we still believe that it's very important to interrupt the transmission at the source, at the initial source, which in many cases are restaurants and bars. And so these settings, and also some social gathering, of the young people. And so the intervention in these settings are still important to prevent the transmission to elderly.
Okay, I know your point. Okay, let me give you a final question that in some prefectures, we used to use the cluster approach and follow up the positive cases. But now some prefectures, they are trying to do some community surveillance. In the limited areas, they try to test for even the community and asymptomatic cases to follow up the how the prevalence of these areas, the corona cases. What do you think this another strategy? Some people say it's disaster. They don't they don't use the proper way of using the limited resources. But what do you think?
Since we still do not have the clear picture of clear overall picture of COVID-19, especially among young people, and so this type of the study, the other study, this type of thing can be done as a cross-sectional study to understand what are going to happen in young people. In a certain area, you can test the people, especially the young people, to know the real prevalence or the incidence in the young people, and also what kind of the transmission, the pattern are occurring in this setting. But it's not feasible to repeat the type of the mass testing. In some countries, they are trying to do this kind of mass testing as the routine interventions, but it's quite challenging. And also if we cannot test everyone who are likely to be infected, then we still miss some of the infected individuals. So the routine mass testing, and also the PCR testing is not the perfect. The sensitivity is not that high. The real-time PCR itself is quite sensitive, but for COVID-19, especially in those in the early stage of infections, tend to be negative, even if they are infected. So we have to understand the limitations of the PCR testing to implement such measures. But still, some cross-sectional study is useful to understand the real situation, the overall situation.
Okay, thank you very much. I think something is very controversial, but I want to discuss more. But unfortunately, time is limited. But through this 1 year, I think that your strategy is very coherent, and we hope you still work very hard for the national strategies setting. Thank you very much.
Thank you very much.
Okay, so thank you very much, Dr. Isono, Dr. Tanaka, for moderating the QA session. And thank you very, very much, Professor Oshitani, for answering to lots of burning questions. Actually, we got more than 100 questions. I believe all the audience enjoyed learning comprehensively about Japan, comprehensively about Japan public health approach discussion, and this knowledge would be helpful to all of them. Once again, thank you very much, Professor Oshitani, for taking part in this webinar.
Thank you very much.
Thank you very much. And before closing, I would like to share information on upcoming webinar, etc. We are planning to organize this kind of COVID-19 webinar series about once a month, hopefully. Next webinar is around the middle or late February on COVID-19 case management in Japan. We'll invite experts who engage in developing case management guidelines in Japan. We will send email to the participants who agree to receive information from us about the detail if we are ready. Looking forward to your participation next time too. In order to make our program better, please provide us your feedback on this webinar. It takes only a few minutes to 5 minutes to fill in the feedback survey. So again, thank you very much for Dr. Oshitani for sharing your valuable insights. And I hope we can discuss again in some time later.
Thank you very much.